Welcome everyone to the August 20th, 2021 Washington Medical Commission Business Meeting. I understand we have a quorum. Amelia, would you like to introduce my favorite word, housekeeping, for the meeting?
Of course. Good morning and thank you for joining us for our business meeting. This meeting is being recorded. The documents which will be discussed here today are available on the event calendar on our website. They're also available in the handout section of the webinar. I am Amelia Boyd and I am the program manager for the Medical Commission. Jimmy Bush and I are the organizers for this meeting. Panelists, please be sure to mute yourself if you are not speaking. Attendees are automatically muted. Please note that anything posted to the chat or questions section is considered public record. We will take public comment at this meeting. Once we get to that item, the chair, Mr. Malden, will read a script and will then ask for public comment. If you would like to comment during this time, please use the raise your hand function or add your comments to the question section. Our time for public comment is limited and each speaker is likely to only have about 2 minutes to speak. And with that, I will hand it over to Mr. Malden for his chair report.
Thank you, Amelia. We won't be talking, well, we will be talking, but Melanie will be going over the strategic plan, but I want to take this opportunity to recognize Jimmy Bush for the outstanding formatting, graphics, and the whole look of the strategic plan. I think she did an outstanding job. It's very readable, it's eye-catching, it's contemporary, and well done, Jimmy. The other person I'd like to recognize today is someone we all know, and that's Melanie. She introduced a new initiative on patient-focused education. So it's something that we can all do better at as patients. So it's for everyone, even commission members. We had a preliminary workshop and came up with a whole bunch of ideas of who we should collaborate with and ideas on how to introduce and develop some initiatives for patient education. And you know, it's how to be a patient, and maybe with the new Cures Act, how to be a patient. But it's really a good idea, and as Melanie said when she introduced it, we do a lot of work with licensees on training and so forth, but we don't really focus on patients very often, and we ought to do that. So thank you very much, Melanie, for that idea and the work that will be moving forward. The other thing I want to mention is the commissioner retreat that we have scheduled for December 9th. Location is to be determined. We are hoping that the meeting can be in person, but given the current status of COVID, who knows what will happen by December. I will be sending out, probably this next week, I'll send out the agenda for everyone to have a look at. If you have comments about the agenda, please get back to me with those comments. I should say that the agenda has been looked at by the executive committee with input and a well-done reorganization by Melanie of the retreat agenda, along with assigning staff members to certain sections of the retreat agenda. I think it was Alden who said this is a very aggressive agenda, and it is. I'm hoping we'll get through it, but I agree with Alden. It's aggressive, and we may not get through everything in one day. But look for that exciting document in your email very soon. The next item on the agenda is the consent agenda. It contains 2 items, the July 9th, 2021 business meeting minutes and the business meeting agenda for today. I will entertain a motion to adopt the consent agenda. Thank you, Dr. Small. Is there a second? Thank you, Dr. Murphy. Thank you, Teresa. All in favor, say aye. Opposed? Opposed? I'm going to take it that aye was not opposed. Motion carries. Next item, I already gave it a brief introduction. This is strategic plan. Melanie, take it away.
Thank you. So for those of you that are new and those of you that are returning, this is the strategic planning process has changed every single time we've done it. So this is the third, I believe, strategic plan that I've been involved with since I've been with the commission. And we wanted to sort of update it, give it a little different look, reformat it, make it easier to read, make it easier for those for those that are not part of the commission to understand where we were going. And so Jimmy Bush was the person who managed the process. So I want to thank her for doing that. We started the process by bringing it to the attention of the executive committee probably around January of this year, because we our strategic plans go with the biennium. So they're 2-year strategic plans. Although I do know that a lot of organizations are not putting a time frame on their strategic plan any longer. They're just saying, this is what we're going to look at and then update it as they need to go forward. So you might want to think about that in the future, is not putting it, making it a 2-year plan, but just making it sort of perpetual in nature and updating it as you go. So this is the strategic plan, the new look. We went to the exec committee. The executive committee said, well, a lot of the goals that are part of the strategic plan come from the different units within the organization. And so what we did is we had every unit within the organization. And when I say unit, I mean licensing, administration, investigation, ops and informatics, and legal unit meets together as a group and come up with what they wanted to do in the next 2 years. That was a strategic goal. And we put those together and we group them differently. They're not just in business units. You will see that the strategic plan is grouped like accountability and administration and legislation. So it's grouped a little differently, but each of the business units had input. Jimmy facilitated all of those meetings, and the meetings were over the 6 months time frame. They came up with some draft goals. We collated them. We went back out to the staff. They revised them, and then those became part of the strategic plan that you see before me. The executive committee wanted to wait until all of that was done to review the commission section. So if you Amelia can scroll down to the part where it talks about the commission. It went to the commission executive committee. They came up with some goals that they thought would be commissioner specific. So all of these goals are something that we're going to do together. Let's go through this. So here are the core values. We took the values that were in sentence form in the last strategic plan, and we made them more readable and kind of sussed out the core words that described those values to make it sort of easier to understand and easier to read. So these are the core values. Then we have the mission and vision. If you can scroll up, down, I don't know how you say it. Can you scroll further down in the document? There you go. The mission and vision is just exactly the way it's always been, but we, again, put it under a graphic so that you could see it a little easier. Scroll down, and then we came up with strategic priorities, something for which we were going to look at our business and make sure that everything that we did matched what our strategic priorities were. So these are using data to guide decision making and establish priorities, working in partnership to reduce and eliminate waste, because we're always looking at lean governing and better ways to do our processes, and letting go of old paradigms and embracing new methodology. And that can kind of mean anything that you want it to mean. For example, you just should have received an email today or yesterday regarding closure codes. You may also know that we are transitioning. I say that lightly because we've been transitioning to a new data system for the past 6 years. It's supposed to go live in February of 2023. We call it the Helms project. And in that data system, all the closure codes are going to go away. There won't be closure codes like BT6 or BT7. So we are now changing the way we look at how we do our processes to make sure that those are gone by the time that Helms is put in place, because it's going to be a whole new system. So those are kind of the old paradigms that we're talking about. And then we have strategic goals. And as you can see, if you could scroll, we've put them in sort of what we think are logical buckets. Licensing, because they kind of stand alone. There are some goals for licensing. And one of the things that the policy committee talked about yesterday is, again, we're changing and updating the questions on the licensing application. So that's something that we're doing as well. Accountability includes the investigative goals as well as the legal unit goals. So we put that into an accountability group. Administration and legislation would be ops and informatics, how we do timesheets, legislative agendas, those kinds of things. Outreach is education, and for both commissioners, for patients, and for licensees. And then the fifth goal is the commission, and this is commission centered. So this is what the staff don't know what you want to do as far as a commission goes. And so the executive committee put in some goals for that group within the strategic plan. So this has been in your packet. For this to become the strategic plan, I need to have the full commission vote on it. So we are providing it for you today. Hopefully you've had a chance to look at it, synthesize what we're doing. And what we really need you to focus on is on the commission section of it. Again, the exec committee put some goals in that section, but if you have other goals that you would like to be included in that, today is not the end date for this. It's hard to get something out to the full commission and have you look at it and decide on it within, a one meeting segment. So if you would like to have a lot more time to talk about the goals and get back to us, I would appreciate that. You can read, these are tiny on my screen, so I can't read them to you. But these were the goals for the commission that the exec committee came up with. So I now open the floor for you to discuss the plan and any kind of changes you would like to make. You might not want to take the time this morning to talk about specific syntax or wordsmithing, but if you have a new goal or a different goal, that would be great. All of the wordsmithing and syntax and grammar issues that you might have, just send them to me in an email and we can incorporate that. Although, I would love for you to vote on this today. I don't think that's I don't think that will happen. So think about it, and then we would bring it back to the next meeting for you to vote on. Okay, I'm done with my spiel.
Yeah, so comments, Mr. Anderson.
Good morning. I think this is really great. It's inspiring to read it and to hear you talk about it. And it seems like it's really has a good vision. It's very visionary. So I like it very much. One thing that I didn't see or hear in here, and is anything about diversity and equity. And I know that these are big topics in almost all organizations right now, and I think that's really a good thing. I also know from being somebody who's always interested in those topics that organizationally sometimes in in a sort of a high level document such as this, it's a challenge sometimes to figure out where to put that or if it even belongs. I mean, that discussion always occurs. And with that noted, and perhaps I missed something, and if I did, I'm sorry, but I'm hoping there could be a nod somewhere in here to what I know is the Commission's strong and proven commitment to diversity and equity issues, both within how we conduct ourselves internally as a commission, and also how we deal with complaints and how we decide what to do regarding discipline or not discipline with our respondents.
Well, thank you for that.
I guess
as you know,
sure.
As you know, that we are looking at diversity issues. We have a work group regarding how to investigate and resolve complaints regarding racism and discrimination from patients. We have a work group on health equity and a work group on healthcare disparity. So obviously we are doing that. I think it would be a good fit to put that as another strategic priority. And perhaps because that is an overarching umbrella of how we are looking at our business, as opposed to just having a specific goal in each of the units. So that's a good idea.
Yeah, I agree. It is really a cross-cutting item. So what you I think is really a great idea. But thank you and everybody for the work on this. I really like this.
Dr. Yu? You might be muted, Dr. Yu. Well, while she works on her audio, are there other comments? I can't see everybody, so if you have your hand raised, just go ahead and talk. Doesn't sound like we have any other comments. I do want to just make mention of the commissioner portion of the strategic plan. One item that I wanted to put on here was the Commissioner Code of Conduct policy. I don't think that has changed since I've been on the commission, and I don't know when it was developed, but it is an item that we're going to be discussing at the retreat. So that policy, I'm hoping, will get revised, and with great input from all of the commissioners at the retreat. And also, I should say that when I send out the retreat agenda, I will send out the current code of conduct policy, so you have that as well to look at. But I want to ask, are there any other comments with regard to the commissioner section at this point? Whether you want to add something, delete something, revise something, any comment whatsoever? Dr. Small?
So this is really getting into the weeds, but on number 3, when talking about best practice, might be helpful just to clarify that's, a best commission or board practice, not a best clinical practice.
Yes, it's referring to the commission, not clinical practice. So it is related to our work and our work in the commission, not clinical work.
Right, and that's my understanding, but again, given the fact we talk about standard of practice, et cetera, a lot, it might just be helpful to clarify that in the verbiage.
I can do that.
Mm-hmm.
Again, I can't see everyone. Other comments?
Mr.
John,
Rogers.
this is
Oh,
Claire. And I don't know if this is appropriate for this document, but, and it may be in,
You're
I don't know
getting
what
some
that is.
feedback. Yeah.
Okay. But one of the things that I think I've heard us talk about quite a bit is what is the role of a commissioner as far as, are we a disciplining board or are we a board that supports medical practice and practitioners? And what I'm kind of trying to get at, and I don't know exactly how to say it, is, you know how the medical, oh, sorry, how the Washington State now I've lost my thinking, if I had some thinking. Anyway, we aren't just about discipline, we also are about supporting and about improving the quality of medical care in a supportive way. I think that we are moving a little away from being totally a disciplining board. And I think some of the feedback we've had from the other medical groups has been helpful in seeing that. In other words, not driving someone to suicide, or understanding the stressfulness of our intervention in clinicians' lives, and doing it with compassion and doing it in a supportive way. I think I've seen in the last 4 or 5 years some movement away from being disciplining and a little bit more towards supporting. And I don't know where we would put that, but I just would like to see that. It might be in the initial things where we said positivity. Maybe that's where that goes, it belongs. But the attitudes are evolving on the commission.
I agree with that, Claire. I know when I came on the commission, I was awfully critical of how we looked at things, and I think we have evolved significantly as in a more supportive role. Discipline is important, but so is education, and so is fairness. And I think we are addressing all those issues fairly well. But in answer to your question, I think the mission statement kind of sums up everything that the commission stands for in a general sense. It doesn't get into the specifics of other
Yes,
things. I'm sorry, go ahead.
We've done some really important work in the SMART work. And I see it, you know, I keep thinking about, I think a medical commission 100 years ago was about maintaining a good old boys club profession. And we've really expanded and evolved from that. And we become, especially with the SMART work, a commission that looks at gender issues differently and identifies differently. And I think this does reflect that in a way. But I just wanted to bring that up as something I've noticed about this commission in the last 5 years.
And I think that's a good observation, Claire. I think you're absolutely right on. And during our retreat, I think that's something that we could talk a little bit more about if you'd like. Others would like to do so, but I am in full agreement with your comments. Scott?
Thank you. I just want to recognize, I mean, I certainly appreciate number 3, that we should always look to improve, and I embrace that 100%. Since we're in a facing meeting here, I want to acknowledge that, you know, our commission, I'm very proud of our commission, and there are a lot of people nationally who look to us for best practices, and our commission has been recognized nationally. Work that Melanie De Leon has done, our own staff have contributed. Mike Farrell has published papers that are groundbreaking. Our own staff, Jimmy Bush, has won national awards for what she does with data and presentation. So I just want to take a second to acknowledge that I'm proud of our commission, and it is really doing some leading edge things. Thank you.
Just another comment on your comment. So, you know, innovation isn't limited to talking with other boards and commissions. If you've got great ideas, we want to hear them and we want to talk about them. we'll certainly adopt and discuss and do everything that's worthwhile that improves our process. Yangling, you got audio now?
Yeah, I got it. Thank you for coming back to me. I just have a clarifying question on item number 4. Is this only apply for new appointed commissioner to solicit review?
That's the intent, Yangling, that get started off on the right foot from the very beginning. And that hopefully will carry through your term as the commissioner.
Okay, so I assuming gradually every commissioner there was some feedback from a older, older that prior other commissioners throughout the process. It's a continued process.
Correct.
Okay. Yeah, thank you. That's my only question.
Other questions, comments? Mr. Anderson. I think you're still muted.
Okay, there we go. That's right. Yeah, the discussion about discipline, discipline versus support. It's not really versus. It's like how to balance the two. I think it's really interesting, and it's one we've had since I've started, and one we continue to have. There's in our panel yesterday, there was a discussion about that, and one of the commissioners was concerned that we not just mete out punishment, and I think that's a topic we could talk about forever, but I'm glad to see it in here. And the way I see the word discipline in this document is as a balanced item with other items, mentioned as well. Because personally, I don't see discipline and punishment as being the same thing. But that we could talk about that, forever. But I am glad to see the balance, and I am glad to see the way the word discipline is used in this document. It seems to me it's mentioned in a very balanced, in a way that's very much balanced by other values as well. Thank you.
When I first came on the commission, the word discipline in the mission statement would just flash red print to me when I saw it. It just irritated me. But we do discipline certain doctors, and I think we distinguish between bad behavior docs who really need discipline versus standard of care issues where we look for improved patient care. So we're helping the docs. I look at it that way rather than disciplining the docs, even though I'm sure that's the way they think the commission works. But patient improvement is what it's all about, and improving practices is what it's all about. So that's the education portion. That's it's forced education, but we do hear positive comments from respondents when they go through the process that they were pleased with some of the coursework they took and got up to date on certain items. So that's the positive part of what we do. Other comments? Teresa?
I think it works. Can you hear me?
Yes.
I've been on the commission for 8 years now, so actually a little more than that. And we've become a kinder, gentler, so to speak, commission. Sorry about that. Kinder, gentler in a lot of ways. The iron hand is gone. We're more supportive. I think that's kind of come along with the change in medicine and medical education to be a little more mindful and less punitive. I think that we're strict where we need to be strict and strong where we need to be strong and forgiving where we need to be forgiving. And I really appreciate what this commission does, and I'm proud to be part of it.
For that. I think I am equally proud to be a member of this commission. Other comments?
Mr. Mullen, I've got one.
Okay.
Just in light of the discussion about roles and that sort of thing, and we've got some new commissioners on, I will just remind you that you all, by serving, you wear multiple hats. So yesterday you're wearing your regulatory hat. If you're on panel L, it's regulatory licensing. Yesterday it's regulatory discipline or enforcement. And today you're wearing effectively your governance or board of directors hat. So just to keep that in mind, depending on your setting, your role changes a little bit as a commissioner. So if that can be applied to what you see before you, hopefully that's helpful, but also a clarification for the newer commissioners.
Thank you, Micah, for that. That's a good reminder. Okay, last call for additional comments, questions. I saw a hand, but I don't know who raised it. The Claire?
Yeah, John, I wanted to make one more complimentary remark about Jimmy Bush. I don't know if she's even on this call, but this is the Jimmy Bush Admiration Society. She is such a value to this commission. And I just want to give an example. You know, we were asked to give a talk on the opiates to new residents. And I did that. And I just called Jimmy and she put together the opiates presentation for me. And of course, now we have another request for another residency. But, and I don't want to just flood her with work. Jimmy, if you're here, you can say no to anything, but just calling her and being able to have a world-class presentation available at the snap of the fingers is really amazing. So I think she's such a value to this commission. I want to really thank her for all her hard work, wherever she may be in the electronic.
No is a very limited word in my vocabulary, but thank you.
Yeah, okay, you are here. I'm glad you're here to get some of this feedback, Jimmy, because I really appreciate all you do.
Yeah, Jimmy has helped me put together slides for presentations that I've made. And it's always amazing how professional they are and how quickly the turnaround is. Very, very much appreciated.
Well, and this
Okay.
strategic plan was done entirely, the formatting by Jimmy. So this is an example of her work that she does that's very forward thinking and lovely. And so I kind of wanted to say next steps will be I will incorporate the equity bit in the strategic priorities. We will update the best practices to say best commission practices. And then I will bring it back to the next business meeting, whenever that is, I'm not even sure, for a full vote. And if you have any issue or comments in between that, just go ahead and email them to me.
Thank you, Melanie. Thank you for that presentation.
John,
Yes.
I'm going to interrupt you because Christine's been waving her hand like crazy, and I think she has a
I'm
comment.
sorry. All right, go ahead, Christine.
Thanks, Teresa. I was just going to let it go. I just wanted to echo what a lot of folks said. I'm very proud to be a part of this commission. I've enjoyed the ability to be able to, as Micah said, jump into other areas and wear different hats on panel L and ad hoc groups that are pulled together. And I myself have learned a lot while I've been here, and I just really appreciate the staff and the quick response that comes from every time you have a question. So thank you.
Okay. Last call for anybody who is crazily waving their hand so they can speak. All right, we'll move on. That's new business. We're going to go backwards to old business. The committee work group reports are found on page 26. Are there updates or comments on the status of any of the work group reports? Again, speak up if you have a comment or a question or an update. Can't see everybody. Hearing none, we will move on to rulemaking activities. Amelia, do you want to give a pitch for your highlighted section in the rulemaking activities?
Yes, thank you. So the time in here is actually wrong. The hearing will be at 4 p.m. It should only last about an hour. Right now, I only have one person that has volunteered to be on this panel. I do need 11 commissioners because we do need a quorum. Thank you, Teresa and Christine. So if you could email me if you're available that day, I would appreciate it. And you will probably see more reminders about this over the next few weeks. It is coming up actually pretty quickly. It's about 4.5 weeks away. And we are taking comment on those rules right now. And that comment period ends September 18th, I believe, or the 15th. It's the week before the hearing. And then if you have any questions about this particular rule, just reach out to me via email if you'd like.
And it's at 4 p.m.?
Correct. So it's
Great, that
correct on the
works.
notification. It's wrong in the agenda.
Okay, good. Yeah, I was going to ask you about it because I saw both of them and I wasn't sure.
Do you have comments or updates on all the other stuff you do with rulemaking?
So right now we are still waiting for a couple of our CR 101s to be rescinded. And then you have approved the 102 for the opioid prescribing patient exemptions. I am working on that. So you will probably see a few more hearings over the next 6 months or so. And then there'll be probably 3 rules on the agenda for the policy committee at the November meeting.
Okay. Questions? Let's move on to delegation of signature authority. Micah has some comments about this. We had a discussion about this at policy a while back. Totally misunderstood, but Micah straightened this out and he can speak to it again today.
Sure. So just a brief explanation for those who are not familiar with this document. The chair is able to delegate certain things, what we call signature authority, to the staff to be able to conduct the day-to-day business of the commission. Usually this falls into the buckets that are listed in this document, licensing in particular. We've had some changes in law that affect PAs specifically with remote sites, so we're deleting that. But also based on recommendations from Heather, we are adding in delegation with respect to letters of qualifications to enter the Interstate Medical Licensure Compact. The reason being, these aren't specifically listed in a few places, and they're not technically licenses, but they gain entry to the compact so you can get other licenses. So to have our bases covered, and sometimes we're having denials of these things come up now. We needed to add them to the delegation of signature authority. Beyond those two major changes, or those two significant changes, there's not a whole lot of change in the document. This gets updated every time there is a change in the chair. Any questions?
Hearing silence and not seeing any waving arms, I'll entertain a motion to adopt the delegation of signature authority document. Thank you, Teresa. We have a second. Thank you, Christine. All in favor, say aye. Raise your
Aye.
hand. Opposed? Hearing none, the delegation of signature authority document is adopted. Lists and labels, we have one request for lists and labels. Heather, as usual, call on you to make comments.
Sure. Sure, this is Heather. So you have the one request from the University of Washington and Fred Hutch together, and they would obviously meet the definition of an educational organization, the university. So I would recommend approval.
Answer questions? Hearing none, I'll entertain a motion to adopt or approve, I should say, the label request.
So moved.
Claire, thank you, Scott, for seconding. All in favor, say aye, raise your hand.
I think Micah
Aye.
had his hand up.
Oh, sorry, Micah.
I can wait till after the vote. I just have a question to ask the commission about the reasoning for this request.
Let's see, we still got all in favor, opposed? Further comment? Micah?
So you'll notice that under the how will the list be used, it's regarding a death with dignity given proposed legislation to extend prescribing authority to the professions of PA and ARNP. Given that I'm likely going to be faced with having some sort of putting some sort of opinion out regarding this, and I don't think we've got anything under policy or guideline, I would like to ask commissioners to either send me comments about that, their feelings on that. I know that death with dignity is usually a fairly contentious subject, and so just wondering if it would be possible for those commissioners that have interest to email me their thoughts on expansion of Death with Dignity Act to cover PAs and ARMPs.
Okay. Thank you for the comment. We have approval for the list. So we will move on to public comment. We will now begin the portion of the business meeting to take public comment. The purpose is to allow members of the public to directly address the commission on issues of public concern. Please refrain from providing comments on pending or open investigations or disciplinary cases. We will not be answering questions or responding. Staff will be available after the meeting to answer your questions. Please understand that although the time period for comment during the business meeting is limited, the public can attend and provide comment at commission committee meetings. The public can also contact staff during normal business hours. We welcome written comments as well. Each commenter will have 2 minutes to speak. When you comment, please state your name and who you represent. Would anyone like to make a comment at this time?
We do have 2 hands raised. Dr. Khalif, if you would like to go ahead.
Thank you very much, Amelia. Hello, everyone. This is Mohammed Khalif from the Washington Academy for IMGs. First of all, I want to take this opportunity to apologize to the commission and the staff for some of the comments I made at yesterday's policy committee meeting, and especially when I called the draft written by Micah and his team racist. These comments were out of line, and anyone who knows Micah professionally and personally, including myself, ought to know better. There is no doubt that the draft presented by staff and discussions by the policy committee yesterday were done with sincere intentions. I do very much acknowledge that. I also acknowledge that the staff and commission's strong commitment towards health equity and for their incredible work on helping us operate the IMG work group meetings. Thank you so much, and I look forward to collaborating with you. I do have some, data that the commission requested yesterday on the IMG issue regarding a survey that was conducted by NRMP by 1,430 program directors. So I would love to send that to staff and for all of your review. Thank you so much.
Thank you for those comments. We would certainly entertain any information you have to provide.
Then Dr. Bundy, go ahead.
Can you all hear me?
Yes.
Thank you, Amelia. Thank you, Commissioner Malden and the other members of the commission. I'm Chris Bundy. I'm the Executive Medical Director of the Washington Physicians Health Program. Just a few comments quickly. First, I wanted to thank and acknowledge Dr. Claire Trescott, who attended the WPHP board meeting in June, met with our board, discussed the commission's experience of WPHP, and had a wonderful conversation, I think, with our board that the board very much appreciated. So thank you, Dr. Trescott, for that. I wanted to thank you publicly and make sure the commission knew that you had been helpful to WPHP in this way. I also just wanted to take a moment. These virtual meetings don't give me the opportunity to introduce myself to commission members, and I wanted to say hello and introduce myself to Dr. Lyle. Dr. Lyle, I've been with WPHP for almost 8 years now, and it's a pleasure to meet you. Please feel free to reach out. The commission staffers know how to get a hold of me if you ever have any questions about WPHP, our mission, or how we make the sausage over in our shop. I'd be happy to talk with you. And that invitation, of course, extends to any other commission members who might want to spend some time learning a little bit more about what WPHP does. And finally, I wanted to just acknowledge the work of Micah and the commissioners and the policy committee in an item I think you'll be discussing shortly, which is additional changes to the licensure application. This model of advisory versus questioning around health-related matters, I think represents an innovation and best practice that I'm eager to scream from the rooftops about nationally if you decide to continue in this direction. This is a clear example of the discussion that you were all having that around the culture of the commission becoming more supportive and less punitive over time. This is definitely something that's been my experience in working with you all. It's actually in ways led to the betterment of my own program to be collaborating with you in that way. And I'm deeply involved in licensure and credentialing question reform as a barrier to help seeking for health professionals who have mental health, burnout, and other circumstances in light of the ongoing pandemic and the epidemic of burnout that preceded it. So my work with the Federation of State Medical Boards, the AMA, the American Board of Medical Specialties really dovetails nicely with what you're doing, and I'm eager to hold this out as a model for other states and other programs. So thank you for your work on this issue. That concludes my comments. Thank you.
Thank you, Dr. Bundy. We miss seeing you in person as well and hearing your extraordinary presentation. So thank you. Are there other hands waving, Amelia?
No, sir, that is it.
Thank you. This concludes the public comment portion of the meeting. I want to thank you for your comments. Again, you may provide written comments at any time.
John?
Yes.
I wanted to make a comment about the policy meeting yesterday and the comment about racism. I think for me, it was a helpful comment. I know it was said in a moment of just passionate moment that I think anytime we can stop and think about our blind spots, think about who we are and what we're doing, it's important. I agree it may not have been appropriate or the right comment, but it was helpful for me to stop and think about what is the language in this policy, what impact does it have on various people from various cultures and backgrounds, and what impact, again, it will have on the mix of physicians in the future. So to me, it was a really helpful comment and a moment to stand back and think about it in a way I had never thought of it before. So it may or may not have been true, but it was a helpful moment for me. So I just wanted to bring that up.
Thank you for that, Claire. I think the comments we receive are to provoke additional thought, and certainly the comments made may be stop and think of things as well. So, but thank you for that observation. Nice touch. Okay, we had some lively discussion yesterday in the policy committee. So Karen, take it away.
Hi, everyone. I'm the chair of the policy committee. I found that comment very helpful myself as well, because I was quite surprised. I never thought that, it didn't come to my mind that this was, could be perceived as a racist thing, because that's clearly not our intent. Our intent is to support diversity and support our IMGs to practice in our state. So I will first start with the policies, the number 1 and number 2, which go together. And number 1 is policy determining appropriate practices under IMG licenses. And number 2 is the interpretive statement that basically it outlines the practice agreements. We spent quite a bit of time talking about this, and in particular, I wonder, well, first of all, I wonder if Mike Farrell wants to just kind of fill us in about what we're actually doing, because this is a brief, it's a law for 2 years of licensure and then 2 years afterwards. It's not as a permanent position.
Sure. Good morning, everyone. The legislature passed a law last session to create a pathway for IMGs to have a limited license. These are IMGs who haven't completed a residency, and Micah Matthews worked very, very hard on this. So these are 2 documents to help implement that limited license. The law allows certain entities to nominate IMGs for a limited license, and they're listed there, hospitals and other state agencies. But it also says appropriate medical practice, and that's not defined. So this is an attempt to define that, because the commission is the one granting the license. The commission ought to be the one that defines it. So at the top of the second page, this is our attempt to come up with some kind of criteria that would show that to have a legitimate medical practice that could adequately supervise an IMG with this license. And we talked a lot about the number, and we talked about whether that should be 5 or 3 or even having a number. And there was a lot of feedback, so I'll just end there.
Yeah, thanks, Mike. So part of the thing is that we really, Micah, do you want to say, because you came up with this criteria, would you like to say something first before I say anything?
Sure. I will say that it was pointed out to be after the policy meeting that simply saying Indian Health Services will not cover all tribal settings, and so we would probably need to consider adding tribal health in there specifically to make sure that those are included. And as far as the sub B and the 3 points there, they were provided as a starting discussion point, fully recognizing that as far as the number of physicians, we don't know what the appropriate number will be. We certainly heard arguments for 1 as a minimum, and arguments for something greater. So it's really going to be up to the commission to be discussing what is appropriate for supervising that limited license. And really at this point, the law is quite clear that it's a temporary license, and that the end goal should be getting that practitioner clinical experience and assessing them clinically for readiness to go into a residency.
Thanks, Micah. So we would like to have the commission's input about this. It's something that we really need further input, and we're very interested in seeing the materials the IMG group will forward to us. But there are a couple things about it. First of all, 20 or more physicians is a number that's just, we don't know how many. I mean, the idea was to have it in a larger setting as opposed to a single office setting with one single provider, one single physician or two physicians. Partly if the physician leaves practice, then that would be a problem for the person in this program. So if you have a larger group, and if someone chooses to leave the practice, you still have ability to have a supervisory and a reasonable setup for the IMG physician who is trying to gain these basically work skills to demonstrate clinical care, which you have to have recent clinical care to even begin to get into a U.S. residency. So and then the problem with a too large of a number is it basically there are only certain facilities that can do it. So it limits the ability for the IMG physicians, especially in rural areas or the eastern part of our state who aren't in the greater Seattle area, to be able to have one of these experiences. And there's also in larger settings, there's a lot more competition for these sort of positions by the fact that the large settings have a high number of mid-level practitioners. And they also may have medical students and residents and other things. So we didn't want to limit the options and make it so that they can't find a spot in our state. Then the other question came up of what do you need? Do you really need quality review improvement and insurance program? Is that something that's important? I think ACGME requires a lot of that for training of residents these days. I don't know if they have to have that in the program. Hopefully that's ideally a good thing to have. And then has an established supervision program for mid-level practitioners. Well, do they really have to have that? Why do they? I mean, a lot of these practices may not have mid-levels, but they may have medical students who come to them, or they want some sort of experience trying to work with individuals. So I just wanted to open it up for any comments, and basically whatever we don't. If you don't feel like making a comment today or you want to think about it, please get back to us. This will be coming back. I would suggest you get back with Micah and Mike Farrell about it. Yes, Dr. Small.
So I don't have, and obviously I wasn't at policy committee, so there's a lot of discussion I miss. I don't have a particular magic number, looking at 20 or more full-time physicians, but I think the issue is having enough full-time physicians to provide adequate supervision for the individual with a limited license. So I would just, and I'm not sure how to address that, but just comment that just because a clinic has 20 or more full-time physicians doesn't necessarily mean that any of them have enough time to provide adequate supervision. And then my other comment looking at sub A is, having been in the Army as a physician for 11 years, there are military clinics out there that have maybe one physician or one PA and that's it. So just because something is a federal system clinic, that doesn't automatically mean that they're going to have adequate supervision. So again, I'm not sure how to address that, but I just wanted to make those comments.
Thank you. I don't know I guess some way of assessing whether there is adequate supervision, a supervisory statement or past history. I don't really know. Anyone have suggestions, other comments about this?
I will just add that there is, for this limited license, there is a requirement to complete a practice agreement with the supervising physician, similar to how PAs operate. So there is discussion and dialogue about that very thing in that document.
Anyone else have a comment?
Yeah, I think we need to do some work, obviously, on what the appropriate number is. I was thinking about this after our policy meeting last night. The clinic I go to is, moderate in size. It's big enough to have a pharmacy and eye care, and I don't think there are more than 10 or 11 MDs in that clinic, but certainly sizable enough to accommodate an IMG individual. So, again, we talked a lot about 20 being a big number, but not knowing what that number is, it's probably substantially less than 20 would be appropriate.
Yeah, and often for residencies, they require 3 letters of evaluation. So it'd be nice to have, that's why number 3, from what people see, because when you get international letters, it's hard to really understand, and especially many of them, since the folks are here, maybe several years since they've practiced medicine, and so at least 3 would be helpful to the physicians. But Teresa, did you have some, or Terry Murphy, Dr. Murphy?
Just real quick, I believe, Micah, it's either Indian Health or Native Health Services would be the appropriate wording there. So I know that in Spokane we have both. We have an Indian Health Services, which I believe is the national designation, but the clinics call themselves Native Health.
Dr. Murphy?
Good to know. I was just going on the federal designation.
Yeah, I'm just reflecting on some of the Eastern Slope clinics, Grant County, Franklin County, Benton County, and there's many clinics that don't have 20 people providing care, including advanced practice clinicians, let alone full-time physicians. So I think we're going to land on a number quite a bit less than 20 to, have these rich experiences open for IMGs, like maybe 5. Because, even the clinics that have, many, many offices, it may be only 3 or 5 full-time physicians, and then a bunch of nurse practitioners and PAs supporting, other aspects of the clinic. And yet these are very underserved areas.
Yeah, and we'd like to maintain that option to work in those areas. It would be great training and provide service to our people of our state. Any other?
QHCs as well.
Yeah.
This is April. And you guys may have already done this, but I just am wondering if any of our panel members have contacts with some of the medical education sort of specialists in their regions, be it people associated with some of our medical schools or our residencies, just regarding the requirements that they have with regards to sort of like size of clinic and some of the things that we're talking about are similar to the policies that they have in place for oversight of residents and students. So I just didn't know if that would be a helpful starting place to kind of talk through some of these issues with people that have already working with policies that are in place and have been developed previously.
Yeah, we had talked about reaching out to residency directors, but I guess you're talking about actually those who send in the medical school level out to and what they're looking for. Because people can do, I know, rotations with the solo practitioner, but that's generally a month or 2 months, not
right.
2 years or 4 years. And it limits, being on a residency selection committee and involved in that for most of my career, well over 35 years, it really limits things. I mean, letters of recommendation are always, you know, they're always good. So it's hard to distinguish. I think what we often look for, and we do support at University of Washington, a lot of our programs, a lot of international medical grads, and we take people who we feel are exceptional, who may not have ever had clinical care in the U.S., but there are just things that you're looking for in the application that include a breadth of clinical experience. And especially when someone's been out of clinical care for more than a year or 2 years, and it's challenging. A research job won't help you out. That's why they need this program. But I'll try to look at, you know, University of Washington, the School of Medicine education for what they do for students. I think that would be good. Other folks who are involved in other programs, other universities should try that as well. Okay, any other discussion? No, so that was just mostly a discussion item, and number 2 we tabled until we, because they go together. That was the interpretive statement. Okay, the next one is called the policy on telemedicine. That's on page 43 of your document. And this policy statement was basically taken, Mike Farrell went from 2 policies and put it into one. Mike, do you want to mention anything about it at all?
Sure. You have 2 older policies that are badly in need of updating. So this is an update. This is a guideline, or rather policy, to provide guidance to practitioners practicing telemedicine. It also incorporates the new law, which allows telemedicine consultations without a license. So I'd welcome any feedback you have on this. The next step is to send it for secretary review. So just so you know, it's going to come back to you. So you can provide feedback at that time at a future meeting as well.
Yeah, so we had a discussion about it. We thought Mike did a great job on this. There was one term about extended time, so the duration of time that someone who was taking care of a patient who left the state, I guess, or came into the state is very vague. And we felt it was better to leave it vague. There's a lot of things happening in this space on a federal level as well. There's a lot of interest in telemedicine. Patients and healthcare providers really like it. And so we voted to approve, forward it on to secretary review, and as far as the policy committee. Any discussion of this? As Mike said, you can have opportunity for further comment. Can we take a vote? Do we need a vote, Mike, for this from the whole committee?
Yes.
Yes. So all in favor of forwarding this on for secretary review, please raise your hand or say aye. And anyone opposed? No. Okay. All right, it's going to be forwarded on, and we will see this again. All right, the next document is something we've seen before. It's called Processing Complaints of Sexual Misconduct through this Sexual Misconduct Analysis Review Team. This one we approved, and there is some change in the language, if you see identified in the red, and that's because we didn't approve it before, because we wanted to have acceptable language relating to sex and gender. Mike and I don't know who else, someone else, Melanie, I think both worked on this and reached out to people to come up with what would be appropriate language that would not be offensive to anybody. And if you see here under it's the red, the team will also contain a member who identifies as female and a member who identifies as male. There's also on page 2, this same language is listed there. There was one word that we added, which I don't see on this document, which is after line number 4 under 5. It's commission member, just to have the right, there's no word member there, but it would also include this. It says same language, commission member who identifies as female and at least one commission member who identifies as male. So we approved the document with the changes, and might just add the other word member on this. Any discussion of this item? I don't see anyone. If I miss you, please yell out. Okay, so we'll take a vote. All in favor of approving this document with the changes indicated there in the word member? Anyone opposed to this? Okay, this document's approved. The next document is on page 51. It's called Interactive and Transparent Development of Evidence-Based Policies. This one we've seen as well. We referred it back to a work group. There are a number of us worked on this. One of the concerns is the terminology of guidelines, because guidelines now with guidelines for practice, they're generally they're done with a systematic review. It has a specialized meeting now in medicine, since so many of our specialties and societies do these clinical practice guidelines. And we felt we were more working on a policy level. So Mike, we voted to approve this. Mike, do you want to say anything about this or not?
No, nothing to add.
So do we have any discussion of this? Yes, Dr. Small.
So one thing, this is really in the weeds again, but the very first sentence there where you crossed out use best practices has the word TO before and after that. So you just need to take one of those out. Thank you. We didn't notice that. It's good you good proofreader. my other question is, and I should know this, do we still have documents that say guidelines on them? Because if we do, we need to modify those if we're going to approve this. My understanding is yes, don't we, Mike?
Yeah, you got a number of them.
Yes. So those will have to, titles of those have to be modified if we're taking guidelines out of this, I would think.
I thought that would be step 2, because I don't have a good substitute for the term guidelines. I kind of like the word guidelines, but if you want to change that term, I'm open to a different word.
I don't know if anyone has any suggestions about that. I guess we felt we approved it and we thought that would be something that could be dealt with later on.
Yeah, I just wanted to point that out.
Yeah, Claire?
When we were doing the opioid rules, the guidelines, that word came up frequently to discuss. Is this required or is it just a suggestion? It seems to me that we had a lot of discussion about what the meaning of the word guidelines was, and that it did have some historical precedent in medicine as to how it's used. And I can't remember all of the issues with it, but it was a really important word for us to kind of sort out as we put in the opioid rules. And Bob, you were in all those meetings, but the word guidelines came up a lot. And we need to go back and look at some of those documents and understand the impact of taking it out of this, if it makes any difference. So,
yeah.
I wish I had more clarity. It had to do with whether a guideline is a rule or just a suggestion.
Yeah, it's complicated, and I think that's why we decided that since this was a 5-year update, to just deal with policy and then worry about guidelines later. Because
Okay.
it requires a lot of I mean, it seems silly, but it is complicated. Didn't we have like a 2-hour discussion over this on a work group as well? And this is what we came up with. So in the next work group, Claire, Dr. Small, you guys.
Yes. I think we spent years on, it feels like years on the opioid rules.
Yes, they will not go away. But it is true. Is a guideline a requirement, or is it just a nice suggestion that you can follow if you like?
Well, I know for our society, ASA, I do run that, chair the committee that puts these things together. We have an explicit statement that the practitioner is allowed to deviate it from based upon clinical circumstances, and that is not a standard for care. A standard is different. That's the level of minimal care. So it depends, but I think other people think of a guideline as a standard.
Right.
Dr. Wilms.
Right. You able to hear me okay?
Yes.
Good. Yeah, medical legally, in a court, a guideline cannot be used to prescribe standard of care. So it would be the same in this setting.
Dr. Murphy.
At the bottom of page 3, it's crossed out in green. It actually has the definition of guideline, not defined by statute, a set of recommended practices. A guideline does not have the force of law, but may be considered by the medical commission to be standard of care in our state. So I don't mind that we take it out, but we'll have to address it later with maybe a guideline policy.
Yes, Mike.
I just wanted to clarify. Guideline is not defined by statute, but policy is. So there's a formal procedure for adopting a policy. Goes through secretarial review, and then it's filed with the code revisor's office. We created the guideline, a guideline ourselves. There's no statutory definition. So this definition in that footnote is something that we came up with long ago to explain. And the advantage of having a guideline or something that's not a policy is that it doesn't go through that process. It can be adopted quicker, and we can also use our own format, which some people think is important. I think it's important. So that was the advantage of a guideline, something that is not a policy. You could take all your guidelines and turn them into policies. We'd have to put them through the formal process. It would take time, but you could do that. Or you could come up with some other word for these documents that are intended to provide guidance to your practitioners. That's the purpose of a guideline, to provide guidance to your practitioners without the formality of a policy.
How about a best practice?
Sorry, I didn't see who's talking?
That was me, sorry, Melanie. You could call them best practices if you wanted to.
I guess we felt it was just better to work on that later on. Just that's why we approve the document as with just policies, because there is so much discussion over what the word is and what the meaning of the word is. And that was us. I don't know if people want to refer it back. And if you do care about this semantics, please be part of the work group. Best practices, Melanie, is something people had considered. I just felt that there was some concern over that too. So should we take a vote on this, or you want to just, yeah. So, well, we recommended to approve the document dealing only with policy and to work on the other piece of guideline versus best practices versus some other terminology later on. We had a lot of discussion of this and wanted to see how many are in favor of just accepting this as policy and setting up a work group to deal with the other one, which was what we were guideline versus best practice versus whatever. Just all in favor, if you could raise your hand or say aye. And then anyone opposed to this? No. Okay, so at least this policy one is done. And then if you are interested in the subject, please do try to volunteer. Talk to Mike and he can put together a group of folks who are interested in it. Thank you. All right, the number 6 is, all right. And this one that we heard from Dr. Bundy, Micah, this is about the revisions. I think you mentioned a little bit about it, but it's basically revisions in the application. Would you like to point out the changes here for folks?
Sure. So this came out of a panel L discussion where there were largely misunderstandings between the lay interpretation of a question relating to legal action in someone's history versus how a lawyer would read it or how a physician would read it. And so that really generated this effort to revise the questions. As we went through, there were there's always been friction between the medical commission and other public stakeholders regarding asking about medical conditions. By adopting this language to go forward in our questions on our application, you would not be the first to eliminate the question about medical conditions, but you certainly would be one of the few. North Carolina, to my knowledge, is one of the ones who has eliminated that question. So the only thing you're asking at this point is, do you currently use a substance that impairs or limits your ability to practice with reasonable skill and safety? And then currently being defined as 6 months. We also explicitly state in the first paragraph what their responsibility is in applying, which is to contact WPHP if they have a substance issue or a medical condition. And if they comply with WPHP's recommendations, then they would fit within the safe harbor that we already have in our questions, and they can answer no to the question 1. Beyond that, there was condensation and attempts at elimination of questions to shorten the personal data questions. The question that initiated all this is question now 2. Where we clarify and clarify that we're asking about adult violations, and then we separate each type of violation out to try and make it clearer and more understandable what we're getting at. Beyond that, the questions are largely similar. We do now ask specifically about hospital privileging actions, whereas before it was more implied, I believe. So beyond that, that's what the proposal is. I want to thank Marissa Courtney and Emma Marienthal from the licensing unit for their work on this, as well as Dr. Brown agreeing to lead the effort.
Thank you. The policy committee really liked the changes that were made. There was one correction that was made up in the first paragraph. Mike Farrell, can you scroll, or whoever's scrolling? And it had to do with the word line 3, inquire about current substance use. Must be up higher. First paragraph. inquire, it's not substance use history. We got rid of the word history. We were talking about current substance use. And there was a typo, which we didn't know whether it was a formatting issue or what, in the second paragraph under acknowledgement and agreement, line 246, where the and licensing ran together. I'm not sharing my screen, but if you look down in the second red line, it's over there. And I believe that was all we made in the changes in our approval. Dr. Wilms?
Right. Mike, can you scroll back up where medical condition is defined? It says medical condition includes social, behavioral, physiological, and psychological conditions or disorders. So is this purposely leaving out physical or not?
I think, to me, physiologic is physical, is it not?
Is it?
I mean,
is that what it's intent to encompass? Physical disorders versus?
That's correct.
So yesterday we had a case of a physical disorder that really didn't have a basis in physiologic, but in physical disorders that caused impairment. So I just want to make sure that this sentence includes covering pure physical disorders.
well, I thought he
might
had
not have
impairment because he had hypoxia.
Yeah, it led to physiologic, but it was a physical.
Yeah, I agree.
basis.
I think, I don't know. I think physical would be, because physiologic comes under physical. And there may be a physical, like to me, someone who loses an arm, for instance, is a physical problem, but it may not have any internal physiologic effect.
Exactly what I was thinking.
Yeah. Do we
Is
want?
there a proposal to add that, add the term physical to the sentence?
Well, then there's no question it covers everything. Physiologic might be a product of a physical disorder, but a pure physical disorder could occur without a physiologic consequence. So just to be inclusive, I would propose that you add the word physical.
Okay.
Everyone agree to that? Seems like a good, thank you for that excellent point. Any other, Dr. Small?
All right, so I'm going to get a little nitpicky again here, and I know Melanie and some of you know that I was involved in revising some of this a while ago. But if you have a medical condition or substance use that may limit or impair, so I think what we're really after there is a pattern of substance use or substance use disorder. I mean, if otherwise, I mean, if I have a couple glasses of wine and then I get called about something unexpectedly to come in, I've just had substance use that could limit or impair my ability to practice medicine. So I don't think we're talking here about, occasional or one-time use, but the way this is written, it could be taken to imply that. And then
substance use disorder is what you want to have the word disorder added after substance.
Yeah, I would either say, pattern of substance use or say substance use disorder, one of those two. And the same thing a little bit further down, if you could scroll down a little bit, Amelia. A bit more. Yeah, so, oops, go back up. Went right past it. Yeah, so do you currently use any substance? Again, so if I drink once in a while, I'm using a substance that could impair my ability. So again, I think what we're really trying to get at is a pattern of use or a disorder, not just any use.
Thanks for those points.
Dr. Domino, just a quick question to Amelia. Is Chris Bundy still on the call? Because he actually consulted with us on this item specifically, and I'm wanting to know if he has some input.
He is, and he has his hand raised. Go ahead, Dr. Bundy.
Hi, Chris Bundy. Thanks for calling on me, Micah. So in the above paragraph, Dr. Small's points are well made. I would actually, my recommendation in the above paragraph, where does it now, up further up, I actually wouldn't call out substance use there. I think you get the same mileage from just saying if you have a condition that may limit or impair your ability to practice medicine safely. Calling out substance use or changing it to substance use disorder has the unintended effect, I think, of stigmatizing substance use disorders or considering them somehow different from other types of medical disorders. And I don't think that's your intention here. So you really covered it earlier on when you laid out all of those different terms of medical conditions, social, behavioral, physical, physiological, and so forth. In the question itself, there are different ways to interpret what that question means. I understand Dr. Small's concern about how the question is worded, but I also would highlight that there are other types of substances used, including prescribed medications for health conditions that nonetheless may have an impairing effect. And so I don't know that you want to restrict this to substance use disorders, but it seems like there is some interest on the part of the commission to have an awareness from the perspective of the applicant, whether they are currently taking something in a manner that may affect their ability to safely practice, if that's a fair understanding of what you're trying to get at here. It's not just the occasional glass of wine, but there are other ways in which substance may be involved in someone's life that could affect their practice.
Yeah, thank you, Chris. That's exactly what I was trying to get at. And I agree with your comment for the first paragraph, especially, with behavioral and psychological. Those are now commonly understood to include substance use disorders. So I would agree with your recommendation about that.
So if we take off the substance use in line number 4, just leave it at medical condition, and we leave the question 1 as the same as it is now, is that acceptable to people? Yes.
So I think for question 1, and again, Dr. Bundy can correct me if I'm wrong, the suggestion there was along the lines of, do you currently use any substance in a manner that impairs, et cetera?
That would be my recommendation, in a manner that impairs or may impair or limit your ability to practice.
That sounds good. Dr. Yu?
Yeah, I totally understand the substance use disorder is type of medical condition. So in reality, I have not dealt with that many cases. So question to Dr. Small or Dr. Bundy. So when the applicants come to fill out those forms, do you think in general they would recognize when you just use medical condition? Do they recognize when they use, have a substance disorder, they would think that also covered in their mind? I mean, in commission's mind, we think we treat that way, but in general, but in their mind, would they do that?
Yeah, so, I don't have hard data to back this up, but in my regular day job, I deal with a lot of physicians and mid-levels in a lot of specialties, not just my specialty. And there's a common understanding these days that includes substance use. And I think for those that don't, question number one is still there, which definitely addresses that particular issue.
Okay. Another thing is that not many, some of those people, provider or general public, when they have a substance use disorder, they don't recognize that affect their ability to daily life or practice medicine. So if you ask whether you have any condition that affect your ability to practice medicine safely, they may not recognize this. How you reconcile that? Sometimes people have, when they have a problem, they don't recognize it.
Yeah, so I just say that applies across the board. That's not unique to substance use disorders. People can have medical disorders that are impairing them that they don't recognize either.
So what if they didn't fill out that, say no, where they get punished? So when we found out later on something, then we know we have cases on that, then we would took action.
Yeah, and I mean that, at some point, someone will potentially recognize that and, make an allegation to the commission and we'll investigate it.
Yeah, you can't do drug screens on applicants. I mean, it's just, you have to rely on people to disclose, and if they choose not to, they don't. And if it becomes a problem, then it becomes a problem. Yeah, and that.
There is data that shows that health professionals do not disclose on licensing applications a variety of health conditions, including mental health disorders for which they have been diagnosed and seek treatment. I think there's a fair amount of data that shows that asking these health-related questions doesn't improve your performance with regard to licensing. In terms of the outcomes that you would think are important with regard to licensing, and serves as an unnecessary barrier to help seeking because people have fears about answering those questions or having to, what happens if they answer yes on the question, or being put in the position of having to make a difficult choice between being dishonest or disclosing. So I think the advisory is a really nice model because it sort of puts the applicant on notice and reminds them that they have an ethical and legal obligation to attend to their health and well-being as a healthcare practitioner without asking questions that are not likely to yield much benefit to the commission. And it also shows the commission's commitment to having a supportive mechanism for people to get help if they are having those problems.
Dr. Trescott.
Yeah, Yunling, where this I think comes up is where someone has truly had problems with substance use disorder, where they've gotten into legal problems or hospitalizations, and it's part of their record, and they understand that they can't lie in that situation. They really do need to put it down, and misrepresenting yourself if it's gotten that bad can be a reason to reject licensing in the future. So this usually comes up where people have had significant issues with it, and people are honest then, and it does sometimes give us a heads up that we have someone that we need to refer to Chris's program. So it's for the people who are still in that phase of a problem where they're in denial and they don't recognize the problem, that this isn't going to pick those up. And there isn't probably any way to pick those up. But in certain situations, it may be helpful for us.
This is a great conversation, but time would suggest we need to move on.
That's right. Should we just delay this for the vote or not? What do you think, John? I mean, we voted to approve it with, like
Yeah,
changes that were
I think
made.
we have, I think we have some new language to consider, so I think we ought to revise it and bring it back next time.
Okay, sounds good. And only one last other thing. This is more of an informational item. We voted, the policy committee voted to form a group, work group, to develop a policy relating to informed consent and shared decision making. If anyone wishes to be on this, please contact Mr. Farrell. Is that right? So you're heading this up. So anyway, that's all the policy report.
Thank you, Dr. Domino, and everyone's for their comments. Let's move on quickly. Member reports. Yangling.
Yeah, just quickly, very brief, 3 of a colleague of mine on HRQ National Advisory Committee, we just wrote a blog on health equity, because the pandemic really exposed the problem and how equity is, and also social divide when we really come into the telemedicine age. And so, you know, the research shows the social determinants of health has a critical impact on the health outcome. So our blog call for action to achieve, you know, the health equity. Also on September 17, the World Health Organization has recognized that day as World Patient Safety Day. So the Patient Safety Movement Foundation is going to organize a series webinars target general public and healthcare providers, and for the patient family and general public, because there are 3 sessions, and I will be the moderator and lead a discussions on patient families. So there were lots of interesting discussions going to be there. And then Washington Patient Safety Coalition will have a patient safety, their annual conference on October 6th and 7th. There's a lot of very interesting talks on open nose and misdiagnosis, and also social equity, health equity. So I will be participating in a session chaired by Dr. Tom Gallagher, and we will talk about how should it involve patient families after harmful events, and you know, basically it's the communications things and the CRP's issue. And then I will be chair and also as moderator on a patient family and a provider on our panel to discuss about how to build a trust and collaborations with the patient families to work together to improve patient safety. So I just thought to give you a heads up on those events.
Thank you, Yanling. Quickly, any other member reports? Teresa?
Yeah, very quickly. First of all, I'm going to be speaking at the Washington Academy of PAs meeting on how to salve or solve your rash, is my topic. And that's in the first weekend of October. Secondly, if you have veterans ages 35 to 65, we're seeing a lot of reactive PTSD to the Afghanistan withdrawal and the situation over there. There is a veterans hotline that you can call. I'm sorry, I don't have the number with me. I can look it up and send it out to folks, but please watch and monitor for your male and female patients that are coming in that may be suffering from anger disorders and other depression symptoms or anxiety symptoms related to our withdrawal from Afghanistan. It's becoming quite an issue throughout the nation, and I just wanted to point that out to folks.
Thank you, Teresa. Anyone else? Okay, let's move on quickly to staff member reports. Are there any updates, additions? The written reports are found on pages 63 to 72. Okay, we've no questions, no additional comments. Heather, you are the anchor to the committee meeting this morning, so do you have
And I have nothing to report, so you can move along.
All right, you're responsible for us getting done quickly. Hearing no other comments, I believe it's appropriate to call the meeting adjourned. Thank you all.
Thank you, everyone.